everyone, I'm Mariana Parks, physical therapist, and today I interview Dr. Eric Dinkins, and he's going to talk about mobilization with movement. Dr. Dinkins is a physical therapist with over 20 years of experience. He is a certified Mulligan practitioner, and he teaches the Mulligan Concept of Manual Therapy in the US. With our discussion today, we will learn about how to incorporate mobilization with Mulligan into your examination, what is the rationale behind it and how to use it as a treatment tool, and also in terms of results, what can we expect and how the patients can perform the movements at home. So if you feel that this information is valuable, please consider subscribing to our channel, clicking on the bell so you don't miss anything, give us a thumbs up, and share this information with other clinicians that may benefit from it. I hope you enjoyed the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi, Dr. Dinkins. Welcome to PT Pro Talk. How are you today?
I'm doing great, Mariana. How are you doing?
I'm doing great too. Ready for the weekend, Friday night, here we are. So let's just get started talking a little bit about yourself, your background for the ones that don't know you.
Sure. I graduated from physical therapy school back in 2001. And, since that time, I've been on a road of a couple of postgraduate certifications, including manipulation and being a Mulligan practitioner and being an orthopedic certified specialist through the APTA and completing my transitional doctorate and just always on a learning curve since then. And I've been with the Mulligan Concept Teacher Association since 2014.
Awesome. So today we're going to talk about mobilization with movement. So let's start talking about how do you integrate it into your examination.
Sure. I think that's where a lot of people tend to have their first questions. People who have taken a course or they've been exposed to it in schooling, they know some techniques or at least what we're trying to achieve with mobilization with movement. But they might not know how to integrate that into the diagnostics or the evaluation portion of the visit. I think one thing that's a challenge for most clinicians is what can we rely on with our examination and the information that we get, and that's kind of a challenge that we have because our special tests aren't so special. A lot of the times, there's a lot that goes into utilizing our special tests and how do we use them. We can't always rely on radiographs, X-ray, MRI, CT scan to necessarily tell us who's struggling and while they're struggling. Basic thing there is just the concept like osteoarthritis is a simple one. Just because you have that, does that mean that you have pain or dysfunction or limitation or not? Or hey, my disc is doing this on the scan. A lot of those things don't add up. Sometimes just talking with your patient can be confusing. How they describe things subjectively can be a challenge. People who report having, never-ending, unrelenting pain, but they'll describe it as a 2. And then a person who says, well, I'll get, 11 out of 10 pain, or I can't move my arm, and we got to figure out why. So there's a lot of barriers, I guess we could call those, to doing a good examination and an evaluation. And there's a lot of factors, of course, going into that. So one thing that should be common with all of our evaluations and leading on to our treatments is, as physical therapists and primary clinicians for a lot of the population out there, we need to just be looking for responders. We want to see who's going to respond to certain treatments, and that can give us a clearer picture of how we want to treat them. So one of the concepts with mobilization with movement is trying to see if we can have designations for people on either some sort of what we call a comparable sign. They might have a loss of range of motion or limited function or weakness or pain or fear. All those things could lead to a person's report on while they're coming to therapy. And so in the mobilization with movement concept, it would be applying different forces across the tissues of the body to see if we can eliminate or immediately change those comparable signs. And so oftentimes in my exam, it is doing my elongated subjective report. It is doing some clinical special testing to try to get a frame of reference of what I might be dealing with, but then also doing a set of kind of discovery techniques to see how a person might respond or if I can change their examination right there in real time. So that's kind of a long-winded explanation of how to get there, but doesn't give us a lot of information about what to do, I guess.
So do you use, let's see if I got it. So do you use the baselines, comparable signs, and then you apply the techniques to see if the person is going to respond, if you're able to change those signs? That's in the assessment, do you use to see if the person is going to respond to the technique?
Sure. Yes. So, over the process of the subjective report, if we create something here, like a person comes in and they can't, they're limited in rotation of their neck and maybe extension. And maybe they have other things that kind of cloud the water. When they do some of those things repetitively, then they start to feel symptoms kind of start to come down, maybe their arm. Hopefully, we've already screened them for some red flags. We don't want to see like a inverted supinator reflex or a Hoffman sign that might say they have myelopathy with that. So we've kind of, maybe done a Sperling sort of test to say, well, I don't think this is, aggravating their complete distal symptoms. And so we're checking off boxes to say, well, I don't think they're at risk of severe harm in my care. So then I'd probably utilize mobilization with movement in those cases to see if I can change the clinical presentation right away. So if I can apply maybe a mobilization with movement to the neck and giving some forces through the tissues of the neck or maybe the spine and have them improve their neck motion without getting any of their symptoms, that gives me a lot of information about how I might try to treat them in that first evaluation. If I can have their exam change from a limited painful motion to a full range motion without getting their symptoms, that usually knocks down a lot of barriers with fear avoidance things, how to self-care and manage their symptoms at home. And then also kind of gives us clear expectation of what to expect for the next treatment coming up. So in that case, as an example, mobilization with movement would be diagnostic first, looking for a responder to those forces. Treatment second, and home exercise third, all in the same visit if they were a responder.
Okay. So just about the techniques that you mentioned, on the assessment, when you're doing the diagnosis, is the technique that you use there the same one as that you're going to use in the treatment? Or are they different? You just kind of see if they're going to respond and then you have to do some tweaks, or there is a progression, or is that the technique that you use on the treatment?
Yeah, another great question, because it's obviously going to depend on the patient a little bit there. So one thing that we can try to screen out for people through just question and answer period is how sensitive and how irritable are the symptoms. So if a person comes in and they say, if I turn my neck to the right 3 times, it's going to start generating a headache. It's going to start generating arm pain. It's going to last for 30 minutes. If I do that, it gets really revved up and then stays irritated. I'm going to have to be a little more cautious in my approach. So if I was to get a nice response with a mobilization with movement to the neck and we got good range of motion, maybe we were even able to apply a little bit of what we call overpressure, I might only do 1 or 2 of those and then see how the rest of the exam or treatment goes. I'd much rather treat less in those cases than necessarily try to give them more, even if that meant not giving much for home program, but rather, I think what we learned today is that your neck has the capability of moving and you don't have to have increased symptoms to do that. That can be super valuable. on the flip of that, if a person's like, well, it's just been there for 6 months, I thought it'd go away, but I don't want it to get worse. You might be able to immediately go into not only the diagnostic that they're a responder as a test, but then multiple repetitions of of movement with overpressure, and then show them how to treat themselves at home, because it's more of a, for lack of a better word, maybe a stable environment.
Mm-hmm. So it would change more the repetitions, the pressure, but not the technique itself.
Now, from a diagnostic standpoint or discovery, no, we wouldn't change that, because we're trying to just discover what the body's going to let us do on that first visit, and maybe on subsequent visits.
Mm-hmm. And like from the subjective, do you have any tips, tools that make you think that this person is going to respond to the treatment, or is just testing and going to the physical exam?
Sure. There's always things that I think people learn clinically through experience of how to pick up on nonverbal body language and other things. But we do have some published research that suggests people who are going to be responders usually are the people that are like, well, I've self-treated my neck with other things before. I don't mind moving. I don't have any kinesiophobia. So just exploring, people who are like, well, what do you think would happen if you were to push yourself further? Well, if a person says, well, I'd probably feel a strain in my neck, that would be maybe someone who's safe to perform, kind of explore more. Someone who goes, oh, I think I might hurt myself. Well, that would kind of tell us, well, we're probably going to have to be very cautious. We might not even want to start with movement assessment types of things. We might have to do other treatments, what our concept would call maybe a nag to the neck, just kind of putting repetitive oscillatory pressures in a weight-bearing status into the neck. And so you can pick up on those nuances. But the people typically that have catastrophizing, they have kinesiophobia, you go to touch them and they change their posture, they kind of guard and shy away. Those are the people you're probably not going to want to force some sort of manual technique onto them too quickly. Unfortunately, I think some clinicians will default then to just, well, maybe some passive modality might help, like needling, or which I'm credentialed to do also. And, I just don't think that a painful response is what you're probably going after with that person for anything. It'd probably be more of an educational session, maybe see if change in positioning allowed them to move themselves, maybe do indirect treatment where they, in this case with the neck, put a laser on their head and have them try to keep the laser stationary and move from the bottom up instead of actively moving their neck. You kind of have to find nuance around that for those people.
Okay. And is the idea that the mobilization with movement should be pain-free?
Yeah, Brian Mulligan, the original founder of the concept, who's still alive and living in New Zealand, so maybe he'll see this. Was he developed the acronym PIL, so pain-free, immediate response, and then you just have to figure out how to turn it into long-lasting. But the P in PIL really stands for any sort of symptom. So I think pain is what people tends to in the community, they get driven to therapy because they're having some sort of discomfort. But if it's just a loss of motion, a person goes, well, I can't move my head to this side, and I started a new hobby, and I need to be able to have that, or I started a new job and I have to look over my shoulder, then that can be a reason to assess with mobilization with movement.
So, and then if you don't find that the person respond with the mobilization with movement, then what do you do? Do you have any other, then you use other techniques to treat this person? Or is there any, you try different directions? What do you do if you find that the person is not going to respond as you wanted?
Sure. I also forgot to mention, as I answer this part of the question, you can use mobilization with movement just to change your exam also. So if you have a cluster of positive special tests, let's say we jump down to the legs and the lumbar spine, and you have some pain with, pavums or pivums, you have a positive straight leg raise, and you have decreased hip motion, let's say internal rotation. And this person has chronic back pain. you could do a form of mobilization with movement to just start eliminating the things that you think might be contributing to them, even though they might not be symptomatic. So if a person has a loss of hip interrotation, maybe you should do an MWM to see if that is what's driving some of their symptoms. If they have a loss of straight leg raise or a painful straight leg raise or tight hamstrings, whatever that means. You could do a variety of mobilization with movement techniques that we have to see if you could just change that part of the exam. That might give you clarity on what's kind of driving their symptoms. But you would probably want to explore that for a while. But if, the hardest situation is person that's irritable. So you're trying different techniques and their symptoms just kind of keep cascading the wrong way. That's where you just kind of have to be willing to shut it down and do something different. But there's always the option of taking what Brian established with looking for responders without their symptoms, and you could do that with exercise as well. You could say, well, maybe you have neck pain. What if I give you some sort of resistive band or isotonic exercise at the shoulder or the neck musculature? Now post-test how you move. So if we were to do some isometrics here or here at the shoulder and the neck, then I'd want to retest. If they were a responder to those inputs, then that's where I'd gear the treatment toward, right? So it doesn't necessarily have to always be a hands-on type of treatment. If the idea is to just look for responders with treatment to help you direct where you're safe to move with the home program, you're likely going to find a lot of success.
Okay, but that's part of the Mulligan too, or is just you as a clinician finding other ways to treat that patient?
That would be using the concept itself without using the techniques. So that'd be myself as a clinician saying, well, if I couldn't establish, a traditional mobilization with movement technique, then I'd look for other things that follow the same pathway. So that, if I have a patient that comes in with patellofemoral pain and simply stretching their quad and doing leg raises, they go, well, that doesn't hurt going up and down stairs anymore. Well,
there we go.
That's what I would do.
Yeah.
Why would I feel compelled at that point to put my hands on them for something else? But that would probably be where I go if that wasn't successful, because then that's easily reproducible for them at home.
That's what I think is super cool, having the comparable signs, because then you can see the response right there with your intervention versus just treating and not really checking baselines to see if what you're doing is effective. So I think that's it's very interesting and valuable for the patient to buy into, and for you to check the progress if you are really changing the patient and helping it. So I think that this idea of mobilizing and then checking, retesting, I think it's very cool.
I think you're touching on some fantastic points there, and I try to reiterate those during the exam, and of course, after that, if we can find something that they're a responder to, then obviously they can modulate their own pain somehow. They can modulate their own symptoms, and that should give empowerment and break down some barriers to patients. Because if imagine the power of being able to, whatever technique you use, let's say it's mobilization with movement, but even if you decide to go a different route, if a person comes in with limited motion, they leave with full motion, or let's say even near full motion, they're going to come back. And that's right there a big thing I think every clinician wants to have, is that there's no barriers for them coming back, because they trust you. You got an immediate result. You didn't have to do it with pain in the MWM concept, in the Mulligan concept. And you're just looking to sustain those results, which oftentimes it's just a matter of saying, well, now that you can move your neck, I need you to just keep moving your neck. I don't need you to do 5 exercises. I just need you to move until you come back, and let's see how you've done.
Yeah. And I was just curious to ask you, so do you use Mulligan more as the base of your assessment, or more like a treatment tool? Is that more like your rationale comes from that, or it's more like, okay, I try a few things and that's another tool that I have?
Yeah, it really is ingrained in the way I think. So I'm going to utilize something toward the effect of, well, how am I going to make a change today? Said in a different way, it's I need the patient to prove to me that they have a condition that they think they have, or that the tests tell me that they have. So then it becomes the foundation for, well, this, if you think you have a condition, but we can change that condition, then even if you truly have that, we're already moving in a very positive direction. So I'm classically using some type of mobilization with movement mind frame for about 80% of the patients that I evaluate. There's always going to be some people who, hey, there's no comparable sign right now. They don't come in with their symptoms, or that's not their goal for coming into therapy. So you obviously would hopefully use other things, for
Yeah.
people.
Yeah. Yeah, makes sense. And then in which specific situations that you feel that mobilization with movement is valuable? So it's more like a specific joint movement, some restrictions of range of motion, just a painful movement? Like, when do you feel like it's more valuable?
Yeah, anything that presents where the person can reproduce it, and that typically is with some sort of movement or load, I'm going to use mobilization with movement as a screening tool to see if I can eliminate that right then. So pain with a squat, pain with a lift, pain with an action of moving something. Something that's probably personal to the patient too, if I can do that first. So if I have I mentioned before, like, well, lumbar related pain. If I have a person that has limited hip range of motion, but that doesn't reproduce their pain, but they have a limited straight leg raise, and that recreates the sign of the buttock for them, or that creates, pain in the posterior element of their body, and they go, that's familiar. Well, it's probably going to do more if I try to change that particular sign, because that's meaningful to them. That, hey, I don't have pain with that anymore. If I change their hip motion, and with the techniques that we use with the mobilization belt at the hip, it usually is very quick. It doesn't take very long to change something if it's going to be a responder. If I go back and I do the leg raise and they go, yeah, I still feel my pain. Well, at least I know that their hip motion probably wasn't providing some of their pain, but they haven't gotten a personal response to that link of, well, now I'm different. And so I'm always looking for those first.
And if they have pain at rest?
Sure. I mean, all these are clinically relevant. So, pain at rest that doesn't change with movement-based things. I don't know how you'd, utilize these techniques unless you're talking about headaches. That's a different type of pain. But if a person's like, well, I can't actually, do something to change my pain, you're probably going to have to do further investigation to see where you think that is coming from. That might be where certain techniques, if they go, well, if I do this, my pain centralizes instead of peripheralizes, well, then you can utilize a form of directional preference with that. I think the concept of mobilization with movement has taught me several things in my career, but it's taught me most probably not to try and just wait on natural history progressions. So, or just try to guess. So if you have a patient that comes in with pain at rest, but it doesn't change with movements, and maybe it doesn't change right away, or it changes later, a delayed onset. So, hey, it doesn't hurt when I sit, but if I sit for an hour, it's going to start to really hurt. But they're in, your office, and you can't stay there for an hour to see what's going to present. You can give them a litany of things. You can give them exercise, you can give them stretching, you can, needle them, you can electrocute them, you can, you can educate them, you can do a lot of different things. You can, use an untuned ultrasound device and see if you can get a placebo response. You can do a lot of different things, but ultimately, you might just be having that person start to, if they feel a little bit better, maybe they'll start to move a little better, and that's going to be probably more natural history progression of just, well, you can do whatever you want, and 50% of our patients are probably going to do better over 6 to 12 weeks. but I don't want to wait that long. If it was my body, I wouldn't want to wait that long. If you were a person that was taking one of my MWM classes, I wouldn't be able to wait that long. I would be like, well, let's make sure we're doing something positive and not causing any harm. So let's try to do that right now. And that's one thing that actually being able to teach the concept is wonderful, because you'll get people, therapists that'll come to your classes, athletic trainers that'll come to your classes, and they've had a condition for years and they're just living with it. And then you can change that in the class, and you can see that everybody learns from that very quickly. And of course, tying that back to your patient, why are we always just waiting to get a result per se? We can likely do more. Some people you're going to have to wait to have it resolve. But I don't try to wait on natural history progression.
Yeah. I was telling you that I did the CART, I think it was like 7 years ago or so. And like I applied some techniques that I think is very helpful, especially like with the belt and the hip. The results are pretty good, like with using the techniques. And now just comparing with the McKenzie, that's what I use the most, I guess, for the last few years. And the extremities that they have been developing over the years has some similarities with Mulligan. Do you use those techniques too? Like, do you see the similarities? Difficult word.
Similarities? Yeah.
Yes. Between the two techniques, because you do like on like the Mulligan, if I recall, you do passive and then the patient does it at home as well, right? So like, what do you feel like is similar and what is different?
Well, I think there's actually quite a bit of overlap between Robin and Brian's, ideas. I believe they were in the same physio class in New Zealand. So, it's interesting just from taking a step back and maybe seeing more of a 30,000 foot view from what they were learning. They learned the same techniques and the same thought process and the same anatomy, and their clinical experience took them in different directions. But ultimately, they were still trying to improve patients where they knew they would get better over time. And so, there's things that I notice in my my presentations in my classes that, the similarities are there. Okay, so I like the improvement from your body if I'm going to take an MDT approach. And I know that if we keep doing this, you will have a really good prognostic factor in improving over time. And in those cases, those are the same thing that we're looking for with the Mulligan concept. We do have some research by people like Chad Cook suggesting that if we can find, improvements very quickly with people, those people tend to prognostically do better over time. There's some other research that suggests the opposite, but we have to treat the patient. We can't just say, hey, well, this research that I've read tells me that it doesn't matter. It's like, well, then I think that you're in a way giving up on your patient if you're not exploring what might make them better right away. So, I think we just need to stay more open-minded, and anybody who's been in the profession for more than 5 years understands that research changes, research methodology is sometimes weak, very rarely very strong. And we have to keep open-minded and say, if that was your mother, would you just say, hey, this is going to get better over the next 3 months, or would you try to do a little bit more for her today? And I can't treat everybody like my mother, especially if they're 20 minutes late to their 5 p.m. evaluation. But I try to keep that mindset with most of my patients. Yeah. I think it's also, worth noting my particular approach. And I mention this in my classes, and I tell people to strive for this. You can have a list of, postgraduate and graduate credentials and all these alphabet soups behind you, but all of us should write really strive for the GBT. So just get better therapist. If your patients are getting better and you can measure that and they can agree to that, I'm not sure the technique really matters, to be honest. Um, and so hopefully people leave, my classes or other classes just saying, hey, I feel like I have more to offer as a get better therapist. And if patients are improving, then
Yeah,
check the box.
absolutely.
Yeah.
Yeah, absolutely. So would you just like walk us through the use of the technique? So like how many times do you do? Like do you have like a number of sets, and then like when you send them to do their homework at home, like how does it work? Like the dosage of the exercise?
Sure. That for me gets back to that. How is the patient acting? What are their beliefs on what therapy is going to do? How sensitive and irritable are they? What do I feel like the underlying tissue problem is? Although I don't use that one as much as I probably learned out of school, because I've just seen so many fantastic things in my career, clinically and then also on courses where you know you can make changes in people's presentation sometimes very, 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 very quickly. Um, and surprisingly, it doesn't take a lot for them to keep that. Probably you can't control 23 hours of the day that you're not going to see your patient. You just don't know what they're going to do. And, I've had the same stories everybody else has where a person goes, oh, my neck felt great leaving, but then they come back 2 days later and, oh, my neck still, it hurts me again. And then they say, you're asking them what happened. Did they do their things at home? And they say, no. Oh, maybe it was because I slipped down the stairs, yesterday. And you're like, okay, well, that would have been important information to discuss. But I have really learned to do less. So I don't try to cloud the water with a bunch of exercises in the first couple of visits. I will give people movement-based things if movement help their symptoms. I will give them posture-based things if posture help their symptoms. Um, the If you are going to add in more more inputs into the body, a variety of ways, then my opinion is that you have to keep retesting. So if I have a patient that can't turn their neck to the right and I do some sort of, snag onto their neck and they can move to the right and they're a responder to that. I will show them with a finger or with a towel how they can do that themselves. How do they feel after just a few repetitions? Well, I feel good. Well, you were also a little weak on exam out here, whatever that means. I'm not sure what that shows up as yet, but when we were doing some prone testing, you were weak over there. So maybe I want to add in an exercise for that. Well, if I add in an exercise for that, I better go back and check their range of motion after I do that exercise. If they feel fine, then it's pretty easy, to be honest. It's, you can probably not go wrong. They're already buying in, they have good motion. You added in some load and they didn't get worse. And so I'd probably just say, do motion, do this load activity or exercise. And let's just keep that simple between now and the next time I see you in 2 or 3 days. If, not everybody's that clean, but I see it a lot that it's that clean. If I do an exercise and they say, that hurts my neck again, that's an easy conversation too. It'd be like, well, I think what we're learning is we're going to have to be a little more cautious with the load on your neck, because adding some load, at least with this exercise, reverse some of the effect that we got before. So let's go back to just having you improve your range of motion, and then I'll give you a different exercise next time I see you. And so it's just a matter of education on that point. And most people understand that. Be like, okay, well, I don't find much value in the days of no pain, no gain, or, well, just do what you got to do. Usually the body's going to tell us what it has to do to get better. Not in every case, but the vast majority of cases. I would say probably over 7 out of 10 of my patients, it's easy to at least align something that says your body's telling us how we want to treat you.
Mm-hmm. Yeah. So like if it's pain-free, do you add overpressure to the movement? Do you progress the force?
Yes. I mean, it doesn't have to be aggressive overpressure. But in-range mechanoreceptor input can be very valuable into the brain, into the S1 and M1 areas. Just remapping what's happening out there, a loss of proprioception if I haven't been able to turn my neck for a while or even a day. The brain just gets valuable information by being able to get onto those end ranges. Similar with McKenzie type of work. Like, hey, if we can start getting into end range motion and centralize that pain, that's usually pretty valuable. So, yeah.
Okay. And do you use the tape after the mobilization? I remember that I learned that, but that's been many years, so I don't know if that's still the case.
Yeah, taping inside the MWM concept is it's pretty straightforward. So it's not the type of tape that or taping concept you might use with like kinesio text or something like that. We're trying to utilize tape to reproduce the same forces that were beneficial to the MWMs. So we're not trying to tape to support structures. We're not trying to tape to offload tissues, because that's kind of hard to prove of what you're doing. I think that can be a negative cycle for people and their experiences, as well as therapists and Twitter chats, things like that. But we will utilize tape if the forces are not good anymore when you take your hands off. So if I have a wrist extension patient and I say, okay, I'm going to get a lateral force along your carpals, so just distal to the ulnar styloid here, and I give you a lateral force, and they say, ooh, I can move further and I don't have my pain. But as soon as I take my hand off, it kind of comes back. So we know they're a responder to the forces. So we would just get pieces of tape and try to pull those in the same direction, and the patient would likely have to help me do that, and then lay those down a certain way that maintains those forces, and the patient and I will know it. They'll say that either is helpful or it's not. If it's helpful, we keep the tape on for the rest of the day in my practice. And, they can take it off if the pain comes back or they get any surface irritation, take it off right away. But that can be super helpful, actually, because then the rest of the day they are grabbing things and turning things and driving and taking off clothing, and they're using their wrist around with that tape as a new input. And so all those for me count as exercise repetitions, so that can be super valuable. So yeah, for people who don't have problems with tape adhesive, it's fantastic.
Awesome. And then when you send them to do at home, the exercises, do you tell them to do like many times throughout the day? Or is one time a day, or there is any specific logic or something, dosage?
I would much rather have a person just keep recreating their comparable sign that they don't have any symptoms with anymore than necessarily add on more exercise. So if a person, let's say with my neck example, we'll keep coming back to that, and that might be different than the wrist. So we'll talk about both real quick. But if a person got increased range of motion to the right, they should know within an hour if they're doing fine. So, if, hey, my neck has calmed down, it feels fine. Well, I'd rather have you do between 1 and 5 repetitions of just neck movement activities. And if you need to do a self technique to facilitate that, then please do. But just move your neck every hour. So if you have an 11 o'clock visit with me, you leave at 12. Hey, sometimes in the next hour, can you have a nice upright posture? Go ahead and try to look. If you have symptoms, do a self technique. Get all the way over there and push on it once or twice, and do that every hour for the rest of the day. Really maintain that input. Don't wait 6 hours and sit at your desk typing away and do this again. I just want you to have that frequent motion. If it's the wrist, if it doesn't hurt, just use it, the rest of the day anymore. If you need to get that repetitive input, then I'm going to do it probably pretty frequently. But if a person has irritable symptoms, or they have maybe a form of allodynia, where they, their response to movement just is irregular, then you're going to do that much less. But most people, again, it's just complementing the increases in motion with frequent motion or light inputs, and then you can build up.
And when you are trying to reproduce the exercise so they can do at home, if they need that extra, the self mobilization or the extra help, do you feel like you can reproduce most of the movements that they do in the clinic so they can do it at home? Or like, do you find difficult at times to kind of teach them to apply the same force, the same angle that you do in the clinic?
Well, that can be a challenge. I try to set that up ahead of time now, as with my experience with mobilization with movement, and this flows over into exercise or anything else for me now too. I want to try to give them things I know it's going to be easy to achieve. So if I have a person that comes in and let's say um, they have a knee strain, I'm probably not gonna choose single leg get ups, from a chair or for them on their first visit, even though it might be appropriate because it just might be really tough for a person who has some weakness and maybe that's too aggressive of an activity. So if I have a wrist extending and I could put them in closed chain, knowing they have symptoms in open chain and closed chain and functionally, closed chain, like a push-up position, that might be hard for them to reproduce that at home. So I might choose to do the open chain things, see if that goes well. I could tape that. I can MWM it, um, do another functional thing so that they can have a hand free. And then if we could explore doing a closed chained activity. I do that every week. So I know those kind of, tricks and techniques. But it might get tougher for people. So we always try to gear it toward, if I have a couple techniques that I could choose, I should probably choose the one that I know that they could probably reproduce at home. If that doesn't go well, I could go to the next ones because I want them to be able to get that input.
Yeah. And then like in terms of results, so do you feel like sometimes in one session you find that direction and they keep doing, they are pain free? Like, does it take a while to kind of like be consistent doing the exercises to see like more lasting results? In your experience, like what can we expect when using the mobilization with movement?
Yeah, so I think that's a great question because, like I mentioned before, the majority of time your patient is not going to be in your care. So they can go home and they can sleep a certain way, they can have stress, they can do the things that are aggravating, but they have to get them done. We're just trying to get them off that carousel, whatever that cycle is. And so um, as a patient there, you want them to be able to um, see that they can take care of themselves and not get that backslide. So for the most part, the hard criteria that I try to keep myself to is that if a person leaves my facility and they had a very good response, so they are a responder to, in this case, MWMs, and let's say we improve their motion from 50% loss to 10% loss. When they come back into my care, I only want them to slide back 50%. So they were better than when they came in, but they're not as good as they left. That's an okay spot because they are, whether they were very compliant or not compliant with their home program, there's some sort of improvement maintained or something that I can say, well, I can start to maximize that, or I can start to move to something else in their exam. If a person comes back and I followed the rules of MWM, they were symptom free, I got overpressure, I taught them how to take care of themselves, and they came back and they go, I've been doing all those things, but I still can't look over my neck or with my neck over my shoulder. That's an automatic flag for me to say, so what am I missing? And that's an easy direction that mobilization with movement can give. If you give someone that is a responder and they come back and they go, I still have the comparable sign that we were working on, I need to start thinking, well, why is that? Because I know I can make it go away or I can significantly change it. And the patient says they were compliant. And I say, can you show me what you were doing? And sure enough, they looked good. I tip, even if they weren't compliant, I try not to blame the patient too much. I know that's an easy low hanging fruit for some practitioners. Well, you haven't been doing your exercises. You haven't been, focused on your posture as much. I tend not to do that too much. That will become apparent visits over visits. But even then, I should be gearing my treatment towards something that's more long lasting. Whether, if they're not long lasting with mobilization with movement, I got to figure out that piece why they're not long lasting. Maybe I need to focus more on deep neck flexor strength to help maintain that improvement. I still know they can move, which is a really good thing, but it's coming back more than I want it to. What am I missing? Is it parascapular strength? Is it repetitive postural load? Is it something else that I'm just not picking up on? So again, the body's response is actually very easy for me to focus in on to determine what I'm missing and what I need to do next, hopefully.
Yeah, it makes sense. Maybe add some overpressure, the McKenzie thinking here.
Yeah. It's
Sometimes.
a common piece that's missed. Yeah, for most clinicians, they're not getting those in ranges. And I think if you can, a lot of different clinicians with different approaches see very valuable things with that. So
yeah, good. Before we transition to the final questions, any other considerations about the mobilization with movement?
We've touched on a lot of good things. I think ultimately just keeping an open mind to conditions, see if they have truly have that condition, and don't let too many information pieces. You want information pieces to help you stay safe, of course, with your patient. But I think information oftentimes works against us as clinicians because we tend to think we know what's going on, and the reality is we just don't know all the factors usually of why a patient is coming to our clinic. So staying a little more open-minded, I think, is just the one of the good take-home messages with mobilization with movement.
Good. So do you have any resource of information that you would like to recommend for people?
For mobilization with movement directly, Brian has written several books. He's on his 7th edition with NAGs, SNAGs, and MWMs. You can find that on mwmusa.com. You can find that on Amazon to get those types of references. We also have a collegiate style text that's very good. It's on his 2nd edition, Mobilization with Movement. You can find those out there as well. I like social media. I don't put all my trust in social media, but as far as gaining information, you can follow hashtags on Mulligan Concept or Mobilization with Movement USA, and you'll find our teachers or other practitioners across the globe that are utilizing different forms of techniques, using the concept and then coming up with their own applications based on what the patient needs. And so I'd seek those out, just kind of explore what could happen sort of things from those. So
yeah, social media is there, and if you use it right, it can be very helpful.
that's the trick. Yeah,
you don't get sucked in the black hole of social media.
Yeah, I guess I could describe myself as sort of a contrarian. I just always come up with a contrary way of thinking or argument for doing different things, and so that kind of keeps me safe. But everything's always changing, so just try to keep up.
Yeah. And what would be the best advice you give to clinicians that are starting their careers?
Well, definitely the first one is, if you are early on in your career, you're within the first 2 years of getting out as a clinician, you need to work in an environment that has other skilled clinicians. So if you are a clinician that just works with one other clinician and you're not sure if their way of thinking and treating is not in line with how you see, it's hard to do, but I would make a switch or seek out that job that has multiple clinicians that you can learn from. Don't work on your own. Even if you feel like you're very good and you're taking continuing education, what you can learn from watching other clinicians is invaluable. I luckily walked into that for the first 5 years of my career, just having top-notch clinicians that I could learn from. Ones that weren't afraid to tell me, hey, that's either not how we do that here, which is a dangerous statement, but at the same time, it's, like, okay, well, you're just trying to better me. It's not personal. And then just take whatever Con Ed you can. It's tough sometimes to travel. It's tough sometimes to have enough resources to take Con Ed. But even if you're dedicating to a single concept, like you did with MDT, or other people are taking classes, SFMA, I think has some value to it. Anything that kind of ties into a concept of how to look at people, you're probably going to find successes. So if it's MWM, fantastic. That's where I lean. Other people don't. I think that's fantastic. As long as we're all GBT, then I think that's great.
As long as the patient is getting better, that's all that matters.
That's right.
If you're having results.
Yeah, I mean, I think most people that have a system of thinking therapy is fun. You're going to see results in the clinic, and you're going to better people's lives, and it's just you go home and you're like, man, that was really cool. If you're not having those experiences, I encourage you to seek out those experiences, because that's the clinical reality for a lot of skilled practitioners. It's fun because it's meant to be fun.
And what personal qualities and abilities that you think are important to become a successful PT?
I think you have to be a good conversationalist. I think if another little bit of a lost art is the willingness to talk to patients about their personal life. Do you have pets? Do you have kids? What makes life good for you? If you're going to have a long relationship with a patient, whether it's certain conditions, post-operatively, or they have degenerative process disease, they were born with a congenital issue, you're probably going to be seeing them for a while. You better learn how to talk on their level and have good conversations, and do like what you and I are doing. Like, well, there's some sort of lead and directive to why we're here, but we can get away from that, at times. So I think that those soft skills are really good to develop, and you can enhance those a lot of different ways. Just general conversation skills can be learned from on YouTube, and getting outside your comfort zone, talking to people at the grocery store, and I had a guy that stopped me at the gas station the other day. We ended up having a 15-minute conversation at the gas station. He had moved in from Texas. He had saw a sweatshirt that I was wearing that I'd gotten from the Jacksonville Jaguars when I taught their athletic trainers out there. And so he thought I was from Florida, and that kind of led to other conversations. And it was just like, this is really nice, because he was willing to kind of put himself out there, and that's good. So I think some of those soft skills are where people can improve a lot of their outcomes without having to be super skilled.
Yes, absolutely. Having that connection with the patient, that alliance, is very important if you want to get them to buy in and do what you ask them. Like, they have to feel like a connection. You are here, you're trying to help me, you are nice, you worry about me. So I think that's very important.
Yeah, and balancing that with still being a professional is a challenge sometimes.
Yeah.
So
you can just be chatting there the whole time, get things done.
That's why people come back.
Yeah. So Eric, if people want to learn more about you or contact you, how they can find you?
They can find me on social media channels at Mobilization with Movement USA. That's going to be Instagram. I am Movement PTED on Twitter. So at Movement PTED for that. And MWMUSA.com has all my personal information on there too. If people want to reach out, I'm super open to that, just about general discussions about therapy, answering general questions. It doesn't necessarily have to be about mobilization with movement. I'm also on LinkedIn if people want to take that. I've kind of checked most boxes, I think, out there. So
Awesome. Well, I appreciate you taking the time, sharing your knowledge with us today, so we get more educated about mobilization with movement, which I think is a very, very valuable tool, techniques that is going to benefit all of us. So I appreciate it.
I appreciate the invite. This has been fun.